This is Dr. Joshua Cooper, and this video on telemetry is going to talk about second-degree AV block. We're going to review the Mobitz 1 versus Mobitz 2 pattern and get into much greater depth than one typically memorizes so that you can understand the reason we care about Mobitz 1 versus Mobitz 2, and we're going to focus more on the physiology of whether the block is happening in the AV node or below the AV node and why that matters. Let's first review what people typically memorize when they learn about Mobitz 1 versus Mobitz 2 AV block. Mobitz 1 or Wenckebach block is typically associated with a grouped beating pattern, here 3 beats clustered together, a PR interval that prolongs up until the point where a P wave fails to conduct, and a narrow QRS morphology. That's altogether the typical findings of Mobitz 1 or Wenckebach second-degree block. On the other hand, Mobitz 2 block is typically characterized by unpredictable AV block, meaning a non-repeating pattern, a PR interval that is the same throughout, and a QRS that is wide. And again, you can memorize those factors and get it right most of the time, but we're going to talk about what each of these patterns means with regard to the heart's anatomy, what the clinical implications are, and that'll help you recognize the exceptions, which certainly exist and are pretty common, so that you can forecast whether somebody has a problem at the level of the AV node or below. Let's review how conduction occurs from atrium through to ventricle. There are 2 stages from atrium to ventricle in the normal heart. First, signals have to get through the AV node, and second, they go down this rapid transit His-Purkinje tree. These 2 components of AV conduction have very different electrical properties, and they fail in very different ways. The AV node you can think of as the lazy, slow part of AV conduction, whereas the His-Purkinje system is the lightning-fast part. And in addition, because the His-Purkinje system forms an electrical tree, the purpose of that tree is to get signals everywhere in the bottom chambers, the ventricles, all at once, to create a synchronous electrical stimulation of those chambers, which is reflected on the EKG and telemetry as a narrow QRS. Why do we care? If the AV node fails, that typically gives us a Mobitz 1 pattern. If the His-Purkinje system fails, that typically gives us a Mobitz 2 pattern. And what is the clinical significance of each? If the AV node is failing, it typically does so in a very gradual, predictable way. And if complete heart block occurs at the level of the AV node, usually the His bundle immediately below can jump in and do the work as an escape rhythm, and the person does not have a systole or bradycardia that is too significant. In contrast, if somebody has disease in the His-Purkinje system, that can progress unpredictably and suddenly, and there may not be anything more distal to the point of block that will serve as an adequate escape rhythm. The person may have prolonged asystole or profound bradycardia that could happen at any time. So if we think somebody is having block in the AV node, it typically is not an emergency, and if the patient is asymptomatic, they may not even require treatment. On the other hand, if somebody's having Mobitz 2 block, His-Purkinje disease level block, then that is an emergency, and that person really should not leave medical care without an intervention, usually a pacemaker of some sort. Let's start by looking at this telemetry strip example. The first thing that strikes you when you look at it is that there's grouped beating. There are groups of 2 ventricular complexes together, followed by little gaps between each little group. The next thing you can do is find the lead where the P waves are the most prominent and identify them all. Notice that in the top and the bottom strips, there are P waves that are hidden inside T waves, which is why I've selected the middle strip in order to highlight the location of each P wave. Next, we look at the QRS complexes, here shown with blue lines. And then last, you can figure out which P wave conducts to which QRS. I'm using a poorly drawn rope and knot to show that that first dotted P wave conducts to that first blue-lined QRS, and there's the next pairing between a P wave and a QRS, and then that third P wave does not have a QRS associated with it, and so on and so forth down the line. You'll notice, of course, that there are some P waves that conduct and some P waves that do not conduct, and that defines second-degree AV block. And as a quick review, first-degree AV block, which many people call first-degree AV delay because there actually isn't any true block, all the P waves conduct. There is a one-to-one relationship between P waves and QRS complexes in first-degree AV delay or first-degree AV block. And in third-degree AV block, no P waves get through. The atria are doing one thing, and the P waves march through on their own rhythm, and the QRS complexes separately march through at a totally different and slower rhythm, having absolutely nothing to do with the atrial activity. That's third-degree AV block. So if we further look at the relationship between P waves and QRS complexes here, you can see that there is, in fact, a prolonging PR interval from one beat to the next on the two adjacent beats that conduct. That defines this, as we reviewed earlier, as Mobitz 1 or Wenckebach AV block, and as we said, that is block at the level of the AV node, not an emergency, not something that requires immediate attention, especially if the patient is asymptomatic. If you want to get fancy, you can call this 3:2 Wenckebach, and that refers to the ratio of P waves to QRS complexes. There are 3 P waves for every 2 QRS complexes. Let's look at this example, which is a little bit less straightforward. Here, we don't have obvious grouped beating in a repeating pattern. There are groups of 1, 2, or 3 at a time. If we look at the PR interval, however, from one conducted P to QRS to the next, you'll see that the PR intervals are indeed prolonging as they were in the previous strip. That actually defines this again as Mobitz 1 or Wenckebach AV block, also at the level of the AV node. The difference here is that you're seeing different ratios at different times, probably because of changing autonomic tone, which we'll review in a moment. And here you see there's 4:3 Wenckebach, 3:2 Wenckebach, and even 2:1 Wenckebach on this same strip. But it's all Mobitz 1 because the PR interval on adjacent beats is clearly prolonging. Again, that suggests that the block is happening in the AV node, not an emergency, not something that you would expect to progress suddenly and unpredictably. Here is yet another strip looking a little different from the previous two because you have fewer P waves that are blocked, and again, not an obvious repeating pattern. The challenge on this strip is that if you start looking at adjacent PR intervals, you're going to see that some of them look identical if you compare sequential beats. That's what starts to get confusing when you see this type of pattern of what's going to turn out to be Wenckebach or Mobitz 1 block as well. When you see longer runs of one-to-one conduction before a beat is dropped, the extension of the PR interval can get very subtly different from one beat to the next. But here is where you can find the Wenckebach pattern becoming obvious. Look for the blocked P wave and compare the PR interval immediately before and immediately after, and you can see that you must have prolonged to get from that 200 millisecond PR all the way to the 366 millisecond PR interval in each sort of grouping. And obviously the numbers may be a little bit different from one group to the next, but clearly you had a shorter PR that progressed to a longer PR, and it's much more obvious if you look at the longest and the shortest rather than sequential beats, which may not be as obvious in terms of their difference. If you also here look at the QRS complexes, you can see that they are narrow, and that suggests that the His-Purkinje tree is actually intact and working well. So when you put all these pieces together in this less common version of second-degree block, it is also Mobitz 1. And the key here, again, is to compare the longest and the shortest PR intervals to show that, in fact, it is changing. And the way to do that is to find the blocked P wave and look for the PR immediately before and immediately after and compare the two. Again, this is Mobitz 1 block at the level of the AV node, not an emergency. Here is that same patient again, but with ambulation, with more catechols, and you can see that the second-degree block has resolved, and now there is a one-to-one pattern between P waves and QRS complexes with no dropped beats whatsoever. This is yet another clue that we're dealing with AV node level problem because the AV node is under the influence of the autonomic nervous system. Sympathetic tone increase, such as during ambulation, physical activity, or giving intravenous catecholamines, will improve AV node function, even in the setting of second-degree AV block. And if you decrease parasympathetic tone, of course, the parasympathetic nervous system, the vagus nerve, has a suppressive or slowing effect on the AV node. If you eliminate that with intravenous atropine, then again, you will improve the AV node function. Conversely, if you increase the parasympathetic tone to the AV node, such as doing vagal maneuvers, a Valsalva, or a carotid sinus massage maneuver, then you should worsen AV node function. If you decrease sympathetic tone, again, you will worsen AV node function, such as during rest or sleep, or if beta blockers are given, which block sympathetic tone to the AV node. There are maneuvers, therefore, that one can do in the context of second-degree block that can further help you clarify whether the block is happening in the AV node, which is under the influence of these autonomic nervous system components, or in the His-Purkinje system, which is not at all under the influence of sympathetic tone or parasympathetic tone. Here's another patient and another strip with second-degree AV block, and let's review this strip in detail. First, we can see that there is grouped beating, but not in a consistent pattern, and that may not be so helpful in distinguishing AV node level block from His-Purkinje level block. But if we compare the PR intervals, we can see that when you find the block P wave as we did before and look at the PR interval immediately before and the PR interval immediately after, there is now no difference between the two. This is different from what we saw before with Mobitz 1 with AV node block. This is instead a Mobitz 2 pattern. In addition here, the QRS is wide, suggesting that there's a problem when beats do conduct with the His-Purkinje tree. So this is Mobitz 2 AV block. This is block in the His-Purkinje system, and it is something we worry about. It is something that is important even if the patient is not symptomatic. This is expected to progress at an unpredictable time frame and could leave you with a dangerously slow or absent heartbeat. So this is a patient who should not leave the medical setting without an intervention, again, usually a pacemaker. Let's think about the His-Purkinje tree in a little bit more detail so that you can think about it the way an EP doc thinks about the His-Purkinje tree. I mentioned before that a normal QRS, a narrow QRS, results because the entire tree is functioning well and signals get down the entirety of the tree lightning fast to give electrical stimulation to the various parts of the ventricular muscle all at once. And the normal tree consists of the His bundle, which is the trunk of the tree, the right and left bundle branches, and the left bundle branch divides into two main sub-branches, the left posterior fascicle and the left anterior fascicle. Many people therefore think of the His-Purkinje tree as a trunk and two main branches, but EP docs actually think more about the sub-branches of the left bundle. We instead think of the three branches, the right bundle branch being one, the posterior fascicle on the left side being the second, and the anterior fascicle being the third. So we think about three fascicles rather than two bundle branches when we're thinking about His-Purkinje disease. You can have 2 out of 3 branches be faulty, giving you in almost all circumstances a wide QRS complex, and that leaves you with only one remaining branch. So EP docs get a little nervous when we see an EKG or telemetry that has evidence of 2 out of the 3 fascicles not working and second-degree block that suggests that maybe that last branch is also not working intermittently, suggestive of Mobitz 2 or His-Purkinje disease, putting you into that dangerous, unpredictable category. Here are some examples of how that might look. So a left bundle branch block, which again you might initially think, oh, that's just one branch, that actually comprises 2 of the 3 fascicles. So just by having a left bundle branch block, 2 out of 3 parts of the His-Purkinje tree are not working, and that'll give you, of course, a wide QRS consistent with His-Purkinje disease. You can have bifascicular block, and there are two flavors. Here's one where you have the right bundle branch and the left anterior fascicle both being blocked, again giving you a wide QRS, worrisome again to the EP doc. And here's the other pattern where you have a right bundle branch block and a left posterior fascicular block. Again, 2 out of 3 fascicles not working, giving you a wide QRS. And there's something called a non-specific interventricular conduction delay. That's just a way of saying the QRS is wide, but it's not in a perfect left bundle branch block or right bundle branch block pattern. And it probably means that there's various twigs in the His-Purkinje tree that are not working well, giving you poor conduction down to the ventricles and poor synchrony, but not in a exact territory distribution that is seen in a typical bundle branch block. But all of these patterns signify His-Purkinje disease, and all of them create a wide QRS. That's why looking at the QRS width can be helpful when you're deciding whether the level of block is at the AV node or in the His-Purkinje tree. Let's move on to 2-to-1 AV block, because this can be very confusing. The reason that 2-to-1 AV block is not initially described as Mobitz 1 or Mobitz 2 is that you can find the P waves. Again, there are 2 P waves for each QRS, but there's no real comparison to be made. You only have one PR interval, and then the next beat's blocked, and the preceding beat is blocked. So there's no way to compare that PR interval to its next door neighbor, because there isn't one. So that really impedes our ability to determine whether somebody is having AV node level block or infranodal block in the His-Purkinje system. Let's look at some tricks to figure out how we can sort this out. One of them is to go on telemetry and find another place where the heart rate is different, hopefully faster, because if the heart rate is faster, that suggests that you may have a pattern other than 2-to-1. So go click on that part of the telemetry and see if you can find 2 adjacent PR intervals that exist, 2 beats in a row that conduct, so that you can now compare PR interval before and after the blocked beat. Here's an example of a patient with 2-to-1 block. There are the P waves with red dots. And we looked at a different part of telemetry, and aha, we found a place where there are 2 beats in a row that conduct. So let's compare PR intervals. Here is the blocked P wave, and the PR interval before and after the blocked P wave is identical. That is suggestive of a Mobitz 2 type pattern, His-Purkinje disease pattern, something that's worrisome. In addition, the QRS here is wide, suggesting that there is disease in the His-Purkinje tree, another clue and consistent with the Mobitz 2 pattern to tell us that in fact we're having block in the His-Purkinje system, something that requires attention. Here's another patient, example number 2, where on telemetry you have 2-to-1 AV block. There are the P waves. We go to a different part of the telemetry and we find somewhere where there is 3-to-2 conduction, so we have a basis for comparing different PR intervals. Here's the blocked P wave, and now we look at the PR before and after, and there is a significant difference. This is a Mobitz 1 pattern. In addition, we look at the QRS width, and it is narrow, suggesting that the His-Purkinje tree is working well. Another clue consistent with the fact that this is AV node level disease. The His-Purkinje tree looks fine. The pattern is consistent with Mobitz 1 AV node level block, not something that's immediately worrisome. Obviously, if the patient has symptoms related to bradycardia, then certainly we would treat that. If there's no reversible cause, such as a medication that's blocking the AV node, then we treat this with a pacemaker for symptom relief, but this is not an emergency. Here's another third example of a patient with 2-to-1 AV block. There are the P waves. And let's show something different in this example. You look at telemetry and the patient's been lying in bed and there's 2-to-1 block and you can't find anywhere to compare. So you can have that patient, you can manipulate the autonomic nervous system by having that patient get up and out of bed. Or if they're not able to ambulate, have them do activities in bed by doing arm exercises or leg lifts or something of the sort to get their catechols up. And if we do that in this patient, you're going to see much better AV conduction. In fact, if you go back to telemetry while you were in the room doing the leg lifts or the ambulation with the patient, you'll see that as the sinus rate was accelerating, signifying increased catecholamines to the sinus node, simultaneously those catechols were improving AV conduction by affecting the AV node. So as the sinus rate increased, the AV conduction improved. That is a clue to suggest that we're dealing with AV node level block because it did improve with increased sympathetic tone. And if we, on top of that, go back and look at a blocked P wave and compare the PR interval before and after, we'll see that we had, in fact, a Mobitz 1 pattern, because now we're no longer 2 to 1. We have 3 to 2 or 5 to 4. So we easily can compare PR intervals through the sequence or before and after the blocked P wave. Clearly a Mobitz 1 pattern. But interestingly, look at the QRS here. It's wide. And so now you have a bit of a conflict or a discrepancy. Before, the examples we looked at were all consistent. And the point here is you can have His-Purkinje disease and simultaneous AV node problem with second-degree AV block occurring at the level of the AV node, which we've demonstrated is true because of the PR interval comparison and the improvement with increased catecholamines. So this person would be expected to have a chronic wide QRS, some type of fascicular block or bundle branch block that is stable, but this person developed AV node problems and this pattern of second-degree AV block. So you can have Mobitz 1 with a wide QRS. So I would put more stock in the PR interval comparison and the response to autonomic changes more than the QRS width. Here's a fourth example of a patient with 2 to 1 block. Again, here are the P waves. And in this patient at rest in bed, the sinus rate is 86 beats per minute and there's 2 to 1 conduction, so the ventricular rate is 43 beats per minute. And in this patient, we also decided to take the patient for a walk. Again, you can exercise their limbs or get them out of bed, and here the sinus rate clearly increased. However, the ventricular rate slowed because now we have 3 to 1 AV conduction rather than 2 to 1. The conduction got worse in the context of catechols. That is not suggestive of an AV node problem. You would have expected AV conduction to improve. So we're dealing instead with His-Purkinje disease because increased catechols made conduction worse. But the question that you have in your mind is, why is the QRS narrow? I thought you said that if you have His-Purkinje disease, then you almost always have a wide QRS because on the beats that do conduct, some of the branches are not functioning. Well, the key word there is almost. There are exceptions to every rule. See if you can think where in the His-Purkinje tree you could have a problem with block occurring causing a P wave with no QRS, but conduction occurring down all the branches. And the answer, of course, is in the common trunk of the tree. If you have His bundle disease alone, and this is, by the way, something that can be seen in the context of an aortic valve surgery or a TAVR, percutaneous aortic valve replacement. Those procedures are done adjacent and near the His bundle. You can have only His bundle disease and intact conduction down all of the branches below the His bundle. And you can have a pattern that is consistent with Mobitz 2, with His-Purkinje disease. There's a reason that we say His-Purkinje disease and not just Purkinje disease. You can see Mobitz 2 block at the level of the His bundle, which is what this is. And we know that's true because catechols made the problem worse. And that's the opposite of what would have happened if this was a problem in the AV node. This is called intra-His disease to EP docs and is also worrisome. This patient should not leave the hospital without a pacemaker or very close observation because just like other Purkinje disease, intra-His disease can progress at an unpredictable pace and can leave the patient bradycardic or asystolic at an unpredictable period of time. Here's another mechanism of AV block, actually in a hospital setting, commonly seen in an ICU. And let me highlight, first of all, that the top strip continues down to the bottom strip. It was just too long to kind of show it in one strip across the page. And let me highlight the P waves here because they're pretty low amplitude. They're better seen on the lower of the two strips. There are two things that you should notice on this strip that are occurring simultaneously. Number one, notice that the sinus rate is slowing. The distance between the red dots with each P wave, the distance is increasing little by little. And at the same time, notice the PR interval is prolonging. The sinus rate suggests something's happening to the sinus node, which is up near the superior vena cava in the high lateral part of the right atrium. The PR interval suggests that there's a problem happening at the level of AV conduction. And with the PR prolonging the way it is, that's a typical Mobitz 1 pattern. You're talking about the level of the AV node, and that's down at the bottom of the septum at a very distinct, geographically different location. How can it be that at exactly the same time the sinus node is having a problem and the AV node is having a problem? And the answer there is the common innervation of the two by the vagus nerve. This is a vasovagal event where you see the vagus nerve feeding into the sinus node, causing it to slow down. And at the very same time, the PR interval is prolonging, and then you get P waves that don't conduct at all, second-degree block. And so the hallmark of high vagal tone, a vasovagal event, is a simultaneous sinus slowing and a PR prolongation before you see block beats. You don't always see this. Sometimes you can see just sinus slowing or sinus pause, or just AV block with very little change in the sinus node. That can be a little bit harder to diagnose, but when you see both happening simultaneously, you should very strongly consider a vasovagal etiology. These are usually self-limited, usually do not require long-term treatment, although in patients who are intubated or have had a neck injury or an abdominal process, something that's causing repeated episodes, sometimes temporary pacing or sometimes even permanent pacing is required. But again, each individual event is usually self-limited and not life-threatening. Again, it's important to remember that the vagus nerve, autonomic tone, affects both the sinus node and the AV node, but not the His-Purkinje system. Let's do a few more practice examples to solidify our understanding of AV node level block and His-Purkinje level block. Here's example number 1. Take a look at the PR relationship, the grouped beating, the QRS morphology, and I'm going to create little checklists so that we can review the principles that we've discussed. Here, let's talk more about AV node block versus His-Purkinje block rather than Mobitz 1 or Mobitz 2. Because really this is what we're getting at. And here's a checklist at the bottom right with some of the principles that we have reviewed. So, is there grouped beating in this tracing? Not really. There's 3, 2, 6, so no repeating pattern. What about the PR interval pattern? If you look at a blocked P wave and the PR before and after, there's a dramatic difference. This is a Mobitz 1 type pattern. And what about the QRS width? It is narrow, suggesting that the His-Purkinje tree appears to be intact. So here we have, in total, a couple clues that point to AV node level block, and that's what's going on here. This is Wenckebach with varying ratios between P wave and QRS. Here's practice example 2. And let's go through our checklist. Is there grouped beating or a repeating pattern here? No, there is not. What is the PR interval pattern? Let's find a blocked P wave and compare the PR interval before and after. They are the same. That suggests Mobitz 2 pattern. And what about the QRS width? It's wide, suggesting there's a problem with the His-Purkinje tree. So here we have 2 out of 3 features very strongly suggesting that we're having a problem in the His-Purkinje system. This is somebody that you want to pay attention to because you're worried about progression, you're worried about asystole. In fact, if we follow up this patient who we predicted had Mobitz 2 block, you will see that they subsequently progressed to higher level block. When we see 2 or more P waves in a row that don't conduct, the term that most people will use to describe that is high-grade AV block. That really means 2 P waves in a row or more that fail to conduct. So this person clearly was in trouble, as we had predicted, because we thought this patient had His-Purkinje disease, and it looks like we were right. If you look at the telemetry over time, you will see that there are these pauses which sort of increased over time. And then you'll look at the heart rate trend. This is where the pauses are occurring, where you're having a heart rate of 0 temporarily and coming back up. And then you plateau at this rate in the low 30s. What happened there? Let's review by clicking on that part of the telemetry and looking at what is the heart rhythm during that time. Here are the P waves in red dots. Here are the QRS complexes with blue lines. The RR intervals are no longer varying. They are absolutely bang on regular, and they have nothing to do with the atrial activity. We have progressed to complete heart block. The atria are doing one thing, the ventricles are doing another thing, slower, and the hallmark of this is that when you put calipers on the QRS complexes, they are exactly the same. That's because there is no conduction occurring. There is thankfully, a new pacemaker spot that has woken up and is causing the QRS beats to happen. And they don't know anything about what's going on up top because AV conduction is completely blocked. So this person had Mobitz 2 block, it progressed to high-grade block, and then progressed to complete heart block. That's exactly what our fear was. Thankfully, this patient was in a hospital setting, and thankfully, this patient did not have asystole for a prolonged period of time, but a junctional rhythm kicked in, and of course, this patient, in short order, got a pacemaker. Here's another practice example. Let's see in our checklist if there's grouped beating. At first, it may not look like there is, but if you look very carefully, and especially if you use calipers, you're going to notice that there's an alternating pattern of shorter and longer QRS intervals. So there actually is grouped beating, groups of 2. It's just that the space between the groups and the groups themselves are actually not too different in their cycle length, so it may not have been immediately obvious to the eye. But if you measure it with the calipers, it becomes clear. So yes, there's grouped beating. Let's look at the PR interval pattern. We found a blocked P wave, and the PR interval before and after is extraordinarily different. This is a Mobitz 1 type pattern. And let's look at the QRS width. It is narrow on the wide side of narrow, but nonetheless, it's less than 120 milliseconds. It's narrow. So actually, we have all 3 checklist items consistent with AV node level block, which is what's going on here. Not a dangerous pattern, not something we're worried about. You would assess symptoms, see if there are any reversible causes, but not somebody that immediately needs attention or pacing. Let's follow up on this patient. In the hospital setting, this patient got out of bed at times, and here you can see that the heart rate actually picked up at those times. And if you put your cursor, you click on the telemetry at those times, you can see that you have actually improved from second-degree AV block to first-degree AV block, where there's a 1-to-1 relationship and no blocked P waves. The PR interval is actually quite long, but in fact, you have a 1-to-1 conduction pattern. We've switched or improved from Mobitz 1 second-degree block to first-degree AV block, or absence of block whatsoever. This is consistent also with AV node level block. So on top of our checklist that we had 3 out of 3 items pointing to the AV node, we actually now have a 4th checklist item, which is that catecholamines improved conduction, further solidifying our assessment that this is block at the level of the AV node, not something that we worry about in terms of safety. So let's review the points from this telemetry talk on second-degree AV block so that you can solidify in your mind how to differentiate block at the level of the AV node from block in the His-Purkinje system. We discussed that the Mobitz 1 pattern usually suggests that block is at the AV node level, and Mobitz 2 pattern usually means there's block in the His-Purkinje system. We discussed that 2-to-1 AV block could be either in the AV node or in the His-Purkinje system, and let's flesh each of these out in a little more detail. Remember that Mobitz 1, the hallmark is that if you find the P wave that's blocked and you compare the PR interval before versus after, you'll see a significant difference. Now I put here by at least 60 milliseconds because another exception that we didn't talk about is that you can see very subtle difference in the longest versus the shortest PR interval of 60 milliseconds or less, which I guess officially is a Wenckebach pattern, but very, very subtle Wenckebach. You can see that in the His-Purkinje system. That's one little box or 1.5 little boxes on an EKG or telemetry difference between the longest and the shortest. If you see that, then actually it may be His-Purkinje disease, and it would fall into the Mobitz 2 category of something worrisome. But if you see a longer, bigger difference between the longest and the shortest PR interval, that pretty much solidifies that you're dealing with AV node level block. And usually, but not always, the QRS is narrow because usually you have a problem in the AV node and a normal His-Purkinje tree, although of course we did review examples where there was a problem with one or more fascicles and simultaneous AV node level block. Mobitz 2 is block in the His-Purkinje tree, and again, the reason that we worry is that that can be a sudden, unpredictable progression to complete heart block, and you may not have an escape rhythm, you may have syncope, you may have a life-threatening situation with asystole. So you need to identify this reliably and make sure the patient gets the proper attention from the EP team. Usually in Mobitz 2, you have a wide QRS, except for that one example where you can see intra-His disease only, where you can see a Mobitz 2 pattern with a narrow QRS. It's important to recognize. It's rare, but it happens. And one of the most common scenarios where we see this is in aortic valve disease with aortic valve procedure done, either percutaneous TAVR or aortic valve surgery. With regards to 2-to-1 AV block, look at other parts of the telemetry for clues, areas where there is not 2-to-1 AV block, where there is 3-to-2, or areas where you can compare PR intervals in sequence or before and after the blocked P wave. And you can do autonomic manipulation either with a medication or withdrawing a medication, or most easily by ambulating the patient or having them do exercise to temporarily increase catechols and see if the block improves. If conduction improves, that would suggest that it's an AV node level problem, not worrisome. Or if it worsens the AV conduction, which suggests His-Purkinje disease, which is worrisome and should require immediate attention. One point that I didn't really make, but I'll make now, is that we can always confirm the diagnosis of AV node level block or His-Purkinje level block in the EP lab. We can do an EP study and put catheters up inside the heart very easily, and we can record atrial signals, ventricular signals, His bundle signals, Purkinje signals, and we can absolutely determine with certainty whether we're dealing with AV node problem or His-Purkinje problem, and of course implement the appropriate treatment. So don't hesitate to ask us, even if it doesn't involve an EP study, we'd be more than happy on the EP end to help you figure out if somebody's having second-degree block, whether we think it's at the level of the AV node and we don't really need to worry right now, or if it's in the His-Purkinje system where this is a safety issue and in fact we do need to intervene, or at least confirm in fact that we're dealing with His-Purkinje disease so that we can do something about it, monitor the patient closely, and implant a pacemaker if that's appropriate for that particular patient. Remember that in a hospital setting, patients can have various reasons for high vagal tone, including at night during sleep and including in the ICU where throat stimulation occurs very frequently and patients are intubated. So patients who have sleep apnea events very frequently will have vasovagal events, even high-grade block, but the key there is to look for sinus node slowing and PR prolongation and AV block occurring simultaneously. In the ICU setting, if the patient is turned or suctioned, that is another common time that you can see vasovagal events. But the AV block pattern almost always here is pretty obvious. You have PR prolongation, which is suggestive of block at the level of the AV node because the vagus nerve innervates the AV node, but not the His-Purkinje system. These events are usually self-limited, do not individually require attention, although if they're very frequent and they're interfering with the patient's care, then sometimes a temporary pacing system is placed, or even permanent pacing. It depends on the specific patient situation, what the impact of these events are, how frequent they are, etc. But it is important to obviously make the correct diagnosis so that you can figure out what is the urgency and what might be the appropriate treatment. I hope overall this presentation was helpful. in distinguishing Mobitz 1 from Mobitz 2, understanding what the implications of each are so that you can think more about the anatomy, the AV node versus the His-Purkinje system, and what the implications would be clinically. Get EP involved, happy to educate and teach, and certainly happy to take care of the patient if you think they require our attention. Thank you so much.